Okay, so with that, I'd like to introduce our speaker this morning. Today we have with us Mary Askew, and she is a charge description master and coding coordinator for Draffin and Tucker LLP in Albany, Georgia. She is a certified coder and directs all charge description master and medical record reviews for the firm. She has 11 years experience in providing healthcare consulting services and 15 years hospital-related experience. So with that, I'd like to welcome Mary.
Good afternoon to everyone from Albany, Georgia. It's 12:30 Eastern Standard Time right now, so I can say good afternoon. I hope y'all have cooler weather than we do. We're fighting 105 and 110 degree heat indexes right now, along with a lot of gnats. So hopefully you're a lot cooler than we are down here. For those of you who participated in the webinar 2 weeks ago that Cindy Dupree presented, if you'll remember, she covered the revenue cycle from beginning to end, beginning with the physician order and ending with the collection process. And today I'm going to cover a very important component of the revenue cycle, which is your charge description master file. And I will be referring to it throughout the webinar as your CDM file. In between the revenue cycle, as you can see on this slide, is your chargemaster file. And what I want to do is go over a few of the components of the CDM. We're going to review a spots related to your chargemaster file. And at the end, we're going to talk a little bit about the upcoming changes that will be made related to ICD-10. Let's start by asking, what is the CDM? And hopefully everyone knows the answer. This slide depicts an actual CDM from one of our clients. And what a CDM is an electronic file in your hospital's billing system. You can think of it as your primary behind-the-scenes vehicle, per se, for accurate billing. In other words, it's your first line of defense against denied claims. Chargemaster contains a comprehensive list of supplies and services with corresponding charges for each of the supplies or services that your facility may provide. The items in your chargemaster are typically grouped together by departments and nursing units throughout your facility. And you're probably wondering, does the size of your chargemaster matter? Well, the answer is no, because it depends on the number of services that your hospital actually provides. I have done chargemaster reviews that have anywhere from 1,500 line items in the chargemaster up to 20,000. So again, the size of your chargemaster just depends on the number of supplies and services that your facility provides. What's the purpose of the chargemaster? Well, it's to accurately list every item and service that your hospital charges for, and it's also used for statistical reasons. Let's go ahead and take a look at the items included in your chargemaster. We're going to talk a little bit about your charge codes, your item descriptions, your revenue codes, CPT HCPCS codes, and your charge. We're going to break these down and briefly discuss each of these. And I understand you're having a hard time hearing me, so I'll speak a little louder. Let's begin with your charge code. Your charge code in your chargemaster is just a unique number or numerical ID related to a certain service or supply. Your chargemaster also contains an item description that goes along with that charge code. It's the actual name of the service or supply. Keep in mind, your descriptions in your chargemaster should not be identical. They should accurately reflect each item and should be easily recognizable to your staff, especially your staff that are entering the charges. And as you can see on this slide, we have two identical CDM descriptions, amputation toe. However, if you'll notice, the CPT codes are different. There's one that has a 28810 and a 28820, and of course the charges are different. So one of my recommendations here would be to be more detailed related to these particular services so that you can differentiate between one and the other. Your chargemaster also contains revenue codes, which are 3-digit numbers used for Medicare billing. Revenue codes are listed in your uniform billing editor, which I'm assuming many of you refer to when assigning your revenue codes. And these are just little snippets or examples from the uniform billing editor. For instance, 45X represents services provided in the emergency room, and 36X are related to OR services. And a little later on, we're going to talk in detail about how important revenue codes are, particularly in critical access hospitals. Revenue codes appear on the patient's bill, just like this example here. In the far left column, you've got revenue code 250, 270, and each of those tells me that this patient received services from sterile supply, etc.
Excuse me, Mary?
Yes?
This is Angie. I'm getting some feedback from participants that they are still having trouble hearing. Are you on your speakerphone or are you using your receiver?
I'm on my speakerphone.
I'm wondering, would it be possible to see if using your receiver
Sure.
a bit louder?
Sure. Is that better?
That's better on my end. So why don't we go with that, and I'll let you know if we're still having issues for other folks.
Okay, sounds
All right,
good. Sorry about that.
All right, thank you.
Uh-huh. Okay, revenue codes tell a payer, such as Medicare or commercial payers, where or in what department a service was provided to a patient. Also found in the chargemaster are CPT HCPCS codes, and I'm sure many of you are familiar with those. These are uniform numeric and alphanumeric codes used for Medicare billing. And I'll talk in more detail about CPT HCPCS codes later on as well. OPPS hospitals are paid for outpatient services under a fee system called APCs, which stands for Ambulatory Payment Classifications. And APCs apply only to OPPS hospitals, not to critical access hospitals. Your CPT HCPCS codes are used to group services into different APC groups. And these APCs are groups of services with similar clinical characteristics that have similar costs based on the CPT codes assigned. Your CPT codes in an OPPS facility are what drive your outpatient APC reimbursement. So if there's no CPT code reported on a bill, there will not be a separate payment to the APC hospital for the UB line item. So these CPT codes are of utmost importance in an OPPS facility's chargemaster, and it's important that these codes are accurate. The different APC categories pay different amounts. And what you need to do is make sure in your chargemaster that the service rendered is consistent with the service reported. You also have your charge amount, the dollar amount that you're going to charge for the services that are rendered to your patients. That's also important in your chargemaster. Can you still hear me?
Yeah, we can hear you.
Okay, I just had some additional background noise.
Okay.
I'm sorry. Okay. So, as you can see, your PPS hospitals and your critical access hospital charge masters are very similar, but when I'm performing my charge master reviews, the reviews are totally different because you're looking at two different ways of being reimbursed. Your PPS facilities are reimbursed based on the CPT codes, and your critical access hospitals are reimbursed based on a percentage of charges. So the PPS CDM review, I would typically focus on areas unique to DRG and APC payments, whereas my critical access hospital CDM focus would be more on areas related to cost-based reimbursement. The compliance focus of both reviews would be similar in both a PPS and a critical access hospital. We want to make sure that we're complying in both type facilities with Medicare and Medicaid regulations. Now I'd like to turn our attention to look at some common hotspots, is what I call them, or common areas where I find problems when I'm doing my medical record audits or CDM reviews. And I'd like to start with talking about revenue codes. That's the 3-digit number we talked about earlier, and I showed you a picture of a claim. And each line item on a claim should be assigned a revenue code. These revenue codes are required for Medicare billing in both your CAH and your PPS hospitals, and they're uniformly used by all payers, Medicare, Blue Cross, United Healthcare, etc. Typically, your revenue codes are hard-coded in your charge master so that they are automatically assigned on a bill when a charge is entered. And they're typically hard-coded in both a CAH and a PPS facility. CMS uses these revenue codes to crosswalk to cost centers in order to estimate the cost of services. Then all of this data that CMS gathers is used to set future hospital outpatient APC payment rates. So you can see how important the revenue codes are in both a PPS hospital and a critical access hospital. If you're a PPS-type hospital, however, inaccurate revenue codes will negatively impact any future APC and DRG payments, but they won't affect your current payments. It's quite opposite in a critical access hospital because incorrect revenue codes will impact a CAH's current payments. In either case, it is so important that all of your hospital systems are working properly and talking to each other properly in order that the correct revenue codes are assigned on the claim form and are billed appropriately to your payer. The major concern, as I said earlier, related to Medicare is the revenue codes in a cost CDM. That's my primary focus when I'm looking at critical access hospital CDMs. Incorrect revenue codes are often encountered when supplies are charged by various ancillary departments such as OR, labs, radiology. In the CDM, if the supply charges may be directly assigned to the OR department, and the OR department will then receive credit for this revenue in their financial reports. However, the supply charges should be assigned a revenue code of 270. They should not be assigned a revenue code of 360, which represents OR, because we're looking at the cost associated with the supply charges. The revenue codes determine which cost centers, such as physical therapy, OR, ER, both the charges and the cost will be assigned. And all of this information that CMS gets is summarized, your revenue codes and your charges associated with each supply or procedure that's been billed. CMS gathers all this information, and Medicare summarizes it into a special report. And this summary report is called a PSNR, or Provider Statistical and Reimbursement Report, which I'm sure each of you are hopefully familiar with. And what Medicare does is they take all the information from thousands and thousands of claims that your facility has filed throughout the year. They take the revenue code and the charges and they summarize it, as you can see on this slide. For instance, the claim form shows a 450 revenue code that tells me this patient received services in the emergency room, and the charges associated with that are $300. Well, what Medicare does is they take all of those charges on that 450 revenue code line, and they summarize it into this PSNR. So basically, it's just a summary of all of your UB04 claim forms that have been filed. And they do that for each revenue code. Medicare then assumes if a charge is billed with a certain revenue code, that this code also represents where the related costs are reported. Just keep in mind, if you're a critical access hospital, that the revenue code assignment is of utmost importance and needs to be accurate. Certain revenue codes indicate that payment should not be made, and this applies to both critical access and PPS hospitals. And I wonder if any of you can think of some services that may not have payment tied to it, or that maybe Medicare does not pay for. Well, if you were thinking self-administered drugs, you're correct. Medicare considers self-administered drugs as non-covered, so it's very, very important that both CAH and PPS facilities assign a 637 revenue code to any self-administered drugs that are given to a patient at your facility. The charges associated with these self-administered drugs need to be listed in
I'm on a conference call.
In the non-covered column, as you can see in the slide that's on the screen right now. So I can't stress that enough. Medicare considers self-administered drugs as non-covered. This is not a new rule. This rule has been out for 10 or more years, and every time, even to this day, when I do my chargemaster audit, I still come across incorrect billing of self-administered drugs. So please get with your people responsible for billing your self-administered drugs. Make sure that they're billing them with a 637 revenue code and with non-covered charges. If you've got the wrong revenue code on non-covered charges, you can be considered as, you can be accused of fraud and abuse. And also, if you bill your self-administered drugs as covered charges, then you're actually being paid for those self-administered drugs, even though Medicare considers them non-covered, because remember I said you get paid based on a percentage of charges in a critical access hospital in particular, And if those charges are in the covered column, then you're actually being paid for something you shouldn't be paid for. And this applies to outpatient areas such as the ER and observation. Remember, observation is also considered an outpatient area. Another hot spot I come across when doing my chargemaster reviews is the incorrect assignment of CPT HCPCS codes. And again, as I said earlier, inappropriate assignment of these codes will affect PPS hospitals because they are paid based on the code that is assigned to a particular service. CPT, as you know, I'm sure, stands for Current Procedural Terminology. And CPT codes are numbers that are assigned to services or procedures that your hospital provides to a patient. Most CPT codes have a payment assigned to them. There are some that do not because whatever they are assigned to are actually considered part of another procedure, and the payment would be tied to another procedure. But most of your codes do have a payment assigned in your PPS facility. These codes play a very, very important role in outpatient reimbursement for PPS facilities. They do not play as important a role in your critical access hospitals. There are some HCPCS codes on your DME prosthetic orthotic fee schedule that some critical access hospitals may get paid for if that code is assigned, but there's very, very few. Again, it's most important that these codes are assigned appropriately in your PPS hospital. As I mentioned earlier, there's payments tied to the services with these CPT codes, and those payments are referred to as APC payments. And CPT HCPCS codes are conditional for Medicare billing. Well, what do I mean by conditional? Conditional means that not every service that's rendered is going to have a HCPCS code assigned. But if there is a code assigned to a particular procedure or service, you need to make sure you assign the code and assign it correctly. CPT codes, you may have in a critical access hospital, you may have some non-Medicare or commercial payers that require CPT codes in a CAH. So I'm finding more and more that critical access hospitals just assign codes across the board no matter what the payer is. But again, I stress the importance of making sure that the CPT code identifies or represents exactly what your chargemaster item describes. Excuse me, I think I might have, no, I'm sorry. CPT codes should always be reported, again, when available in an OPPS hospital because, again, a payment is typically assigned to those codes. If a wrong CPT code is assigned in your chargemaster, that's going to mean you're probably going to be paid incorrectly. If there's not a code assigned when one code exists, then you won't be paid for the services. So again, it's very, very important that you maintain your chargemaster and keep it up to date, especially when there's changes in codes throughout the year. I'm sure many of you are familiar with all the regulations that are issued from CMS. A lot of changes are made with your drug codes for those of you who are PPS facilities, and it can be quite cumbersome keeping up with the changes, but as you can see, those codes are tied to payments, so so it's most important that you have the accurate codes in your chargemaster. Since everybody uses the same codes to mean the same thing, then it's considered uniform. They keep it uniform. And here's some examples of some codes that I've taken out of the CPT code book. 71010 is described as radiologic exam, chest, single view frontal, and 66983 describes cataract extraction. And as you can imagine, there are thousands and thousands and thousands of CPT codes, so you have to be very careful what codes you're assigning to what procedures. Here's an example of your CPT coding book. These are published annually by the American Medical Association. And hopefully all of your revenue-producing departments, such as your X-rays, your X-ray department, your lab department, hopefully they have access to their very own books. Again, these are published annually, which means the codes are either revised or there may be new codes added, there may be codes deleted. So it's important that you stay on top of these changes, and once these changes are identified, that you make the changes in your chargemaster as well. Most of the time, your CPT codes are hard-coded in your chargemaster, which means when you enter the charge, the code automatically goes out on the bill. However, many medical record departments choose to soft code or manually code surgical procedures in the facilities that I have been in, just so that there's more accuracy in the assignment of the codes. As I said, CPT codes often change throughout the year. So if you're using deleted or expired codes, if they stay in your chargemaster, if you're a PPS hospital, your payments are going to be affected. And again, when I'm doing my chargemaster reviews, I often find codes that have been deleted because no one's followed through and made the corrections in the chargemaster. Department managers should be held accountable to review their personal chargemaster section related to his or her department. As I mentioned, your lab and your radiology areas are very important. They need to make sure that any changes have been made related to charge codes or CPT codes in your chargemaster. So again, in a PPS hospital, your CPT codes are what drive your payment, and that will be your main concern in your chargemaster review. If the code is incorrect, the payment will be incorrect, and of course that will affect your bottom line. There are some services in a critical access hospital that continue to be paid under a fee schedule. As I mentioned before, some of your commercial payers, your managed care payers, they are relying on CPT codes to pay for services in a critical access hospital. So again, my main focus in a PPS would be on your CPT codes. The focus on CPT codes in a critical access hospital is not as important, or is not my main focus. Instead, it would be the revenue code assignment. Hospitals, and both hospitals and doctors electronically submit their data using CPT codes. In a hospital, all the services provided are not assigned, and that's a repetitive slide, and I apologize for that. Most supply items used in a critical access hospital do not have a CPT code assigned. Usually it's just the codes are assigned in a CAH to your ER visit levels, your ER evaluation and management visit levels, or your outpatient clinic visit levels, or your procedures. Okay, let's talk a little bit about HCPCS codes. I know I've been throwing that acronym out in conjunction with CPT codes. Oftentimes they're used interchangeable, although they're quite different. HCPCS stands for Healthcare Common Procedure Coding System. And these are what they refer to, CMS refers to as Level 2 codes, and it's a set of standardized alphanumeric codes that describe healthcare equipment and supplies that are not typically identified by a CPT code. And when I say healthcare equipment, your durable medical equipment or DME equipment might have a HCPCS code assigned. Or, as I mentioned before, prosthetics and orthotics oftentimes have HCPCS codes assigned. Other examples where HCPCS codes are used would be your ambulance services, and an important area would be your drugs. Your drug codes are often coded with a J code, and depending on your payer type, it will determine the importance of those HCPCS codes. These codes do not determine coverage or payment in a PPS or a critical access hospital. The payment is typically determined by the payer along with the coverage. And since there are fixed payments assigned to some HCPCS codes, OPPS hospitals should assign these codes when available. Now again, not every DME item, not every prosthetic, orthotic item, or ostomy supply is going to have a HCPCS code available with a payment assigned to it, but if there is one that exists, PPS hospitals should definitely make sure it's in your chargemaster. As I mentioned, HCPCS J codes are often assigned to drugs, and they need to be included in both PPS and critical access hospitals' chargemasters. Again, when I'm reviewing chargemasters in a PPS hospital, if the CPT HCPCS code is incorrect, your payment is going to be incorrect as well. If there's not a HCPCS code or a CPT code assigned to an item, when there is one available, then again, you're going to miss out on some payments for those items that you've billed to the payer. Many times when I'm doing my CDM reviews, I also come across items that a facility no longer uses. And this just tends to clutter a chargemaster. I mean, the chargemaster ends up being bigger or containing more items than it really needs. In fact, I'm working with a client right now, and there are numerous items in there that the department managers have identified that they no longer, either they no longer use a supply or they no longer perform the service. So I know that within your charging systems that there's a little switch or some magical button that you can turn on to inactivate certain items. So I encourage you to do that. If you've got a number of CDM items that you're no longer using, if you'll inactivate those, and that way they won't clutter or become lost in your current chargemaster items. Items no longer used or not reviewed or not typically updated for revenue codes or CPT codes Typically, they're put on the back burner, and because if you leave these codes in the chargemaster, you're going to risk the possibility of people charging for these particular items that are no longer used just by keying in a wrong number or something. So your payment, this will result in payment errors. For instance, if somebody decides to reactivate an item that's been out there and not used for a while and the codes have changed, like I said, they're updated, CPT codes are updated annually. Maybe there's a new code for a particular procedure that has not been used for a while. However, somebody says, okay, we need to start using this. If they have not verified the revenue code or the CPT code assigned, your facility may not be paid correctly. Duplicate billing is also a common chargemaster hotspot when I'm doing my chargemaster reviews. Duplicate billing is common when hospital staff are answering a cardiac arrest code. For instance, if somebody calls a code blue, which may represent a patient in cardiac arrest, we need to make sure that only one charge is entered for the CPR code. I think that code is 92950, and Medicare guidelines tell us that that should only be billed one time. However, if you've got a CPR, CPT code in your respiratory therapy department, and there's also one in your emergency room, you need to make sure that there's communication between those two departments, and so that the billing is not duplicated for that particular CPT code. Again, it goes back to keeping up with the regulations that Medicare issues. And just a little side note, all of the recommendations we make are typically based on Medicare guidelines. And we use those guidelines across the board with all payers. During a code blue, you've got so many departments responding. So again, it's very important that your departments communicate and determine who is actually going to be responsible for entering any charges relating to that code. Again, when you've got so many departments responding, you run the risk of missing some charges. So we're not only talking about duplicate billing or duplicate charging, we're talking about lost charges. So again, it's a team effort, and departments need to be held accountable when it comes to entering charges related to services rendered. There should be a clear understanding when developing your code response charges in the chargemaster as to who's going to be responsible for entering the charge. Again, as I said before, oftentimes I see your code blue CPT code 92950 in the respiratory department, and I also see it in the emergency room. So again, communication is of utmost importance to prevent duplicate charging during a code. Duplicating charge codes often lead to a more cumbersome or larger chargemaster file because it increases the number of line items in your chargemaster. Also, if you've got duplicated charges for services or supplies, that can also distort your inventory or your usage statistics. So you need to keep an eye on duplicated charge codes. I know that a lot of departments, my mouth's getting dry, I apologize. I know that a lot of departments use a lot of the same items, so you run the risk of duplicating charges. Again, it goes back to the department heads being held accountable for keeping their chargemaster current and up to date. Oftentimes, and in fact, the client that I'm reviewing now, I came across some CDM line items that did not have a charge associated with them. Now, I know that some facilities will enter CDM items in their chargemaster just for statistical purposes or just for maintaining staff hours to determine if they can increase their FTEs in their department, and oftentimes they'll put a zero charge if it's a procedure that cannot be charged for based on regulations. But be careful, because some of the items, or most of the items in your chargemaster should have a dollar charge. So you need to go down your list and make sure that a charge is assigned in appropriate situations. Oftentimes I run into problems or errors related to the number of units billed for a particular service. And one example that comes to my mind is blood administration. I'm sure y'all are all familiar with blood administration. Medicare says that you can only enter one unit for the same date of service related to blood administration, regardless of the number of units of blood that has been transfused. And again, this is not a new regulation. This has been out there for a while, but time and time again, I'm still coming across, when I'm doing my medical record audits, I'm coming across more than one unit being charged for the same date of service related to blood administration. So if a patient is transfused 3 pints of blood, you still, on a particular date of service, you still only enter one unit related to the administration code, and I think that code is 36340, I believe. Again, when you're assigning your chargemaster descriptions, it should be closely related to the CPT code description, and it should also be easily recognizable to the staff, especially those who are entering the charges. So your blood administration CDM description should read blood administration per day charge. Oh, this is a big one. Inappropriate billing of drugs. Many, many times there is so much confusion relating to your drugs being billed. And this is where your HCPCS code descriptions come into play. And it's very, very important that your pharmacy is involved in maintaining your pharmacy CDM, and that they work closely with your billing department related to your dosages. HCPCS codes, we mentioned the J codes are often assigned to your drugs that you use in your facility, and they're very specific as to the dosage related to a particular drug. So missing or inaccurate drug dosages in your pharmacy description can often lead to incorrect charges, and I find this all the time. When you're setting up your line items related to drugs in your chargemaster, if the dosage of your facility's stock drug is different from your HCPCS code dosage, then you're either going to have overbilling or underbilling. I can't stress this enough. Lack of understanding of your CDM item descriptions and CPT code descriptions can lead to charging errors, which again will result in over or underbilling. So, go to your pharmacist and say, take the HCPCS code book to them and get them to review the book. Again, as I mentioned earlier, CMS makes changes throughout the year related to drug codes in particular. They may delete the codes. They may change the dosage of the codes. It's very important that pharmacy is very involved with these drug CDM line items. And make sure that your descriptions on the drugs are exactly like the HCPCS code descriptions, or at least if it's not identical, make sure that the number of units that are associated with that particular charge related to a drug, make sure that those units are going through your system and out on the bill correctly. For instance, if you give a Demerol injection, I guess is a good example. And I'm not a nurse, so forgive me if I'm talking to some nurses and I say this wrong. But if you've got a drug or Demerol drug listed in your chargemaster, and you've got it listed as 20 milligrams, however, the HCPCS code description is described as 40 milligrams, you want to make sure that if you're administering the 40 milligrams, you're going to enter 2 units related to your CDM line item to equal the 140 milligram unit that is described by that J code. And hopefully I didn't just confuse everybody. But anyway, make sure that the way you're billing your drugs, the dosages related to your drugs, make sure that you're billing them based on the HCPCS J code description. Oftentimes your computer systems are limited to the number of characters that you can use to describe a particular supply or service. In your chargemaster, for some reason, 30 characters stands out in my mind. I'm sure they probably vary from system to system. But the item description, as I said, should closely match the CPT HCPCS code descriptions in your chargemaster. And they should also be easily recognizable by your staff, especially those entering charges. Your item description should be reviewed periodically, just like all your CPT codes, just like all your revenue codes, just like all your charges. Your descriptions need to be reviewed to ensure that they accurately reflect the service that you are providing to your patients. You need to keep the use of miscellaneous type charge codes to a minimum. An example that I often come across related to miscellaneous charge codes would be, for instance, pharmacy may have a charge code that says miscellaneous drugs. Well, if you're in a critical access hospital, in particular, you need to be careful because revenue codes are going to vary related to miscellaneous drugs. What does that tell me? Are these drugs injectables? Are these drugs self-administered drugs? So I would steer away from using miscellaneous type charge codes, especially in pharmacy. What I would do, if you want to set up a miscellaneous charge code for maybe drugs that are not often used by the hospital, I would set up 2 line items. I'd say miscellaneous drugs and put self-administered and assign the 637 revenue code to it. And then I would set up a separate CDM line item that said miscellaneous injectable drugs, and I would assign the 250 revenue code. So that way, you're not billing, if you just got one line item that says miscellaneous, you would run the risk of billing self-administered drugs as covered charges if you've got a 250 revenue code assigned to it. Again, I would have two line items related to this example that I'm giving. One for self-administered drugs with a 637 revenue code. You would bill those charges as non-covered. And then you'd have a second line item with a 250 revenue code for your injectables. So be very specific when you're setting up your charge codes related to your CDM descriptions. Another hot spot I come across, and related to the miscellaneous type charge codes, they may cause payment delays, or you may actually be denied payment if the payer does not recognize the type of service that you're providing that is described by miscellaneous. Inconsistent pricing between departments for similar items is also a hot spot I come across. You need to keep that to a minimum as well. Third-party administrators, you're probably familiar with their auditing that they do regarding pricing inconsistencies, and they will deny payment if they identify quite a few consistencies. Are your charges too high, or are they too low? Again, critical access hospitals are paid based on a percentage of charges. So if your charges are too low, you may lose some reimbursement if you're a critical access hospital. So you need to, when you're reviewing your charges in your chargemaster, you need to make sure that they're not too low and they're not too high. Again, if they're too low, you're going to lose out on some reimbursement. However, on the other spectrum, if they're too high, this means that the patient is going to be paying additional money because of the copayment that's attached to the charge you've assigned. So if you decide to do an across-the-board increase in charges, which facilities routinely do, you need to think about it and perform a financial impact analysis to see how this will affect what your patient owes. If the patient is going to start owing more, you're going to catch flack from the community and feedback, and it'll be a bigger headache than you expected. But again, do a financial analysis financial impact analysis when you're talking about increasing your charges. Again, as I mentioned before, your PPS hospitals are paid by Medicare using your DRGs, or diagnosis-related groups, and your APCs, ambulatory payment systems, classification systems. DRGs typically pay a flat dollar amount depending on the inpatient's procedure or illness. And APCs, again, as I mentioned before, you've got a dollar amount attached to your CPT code, and your CPT code is paid based on the APC that's assigned to it for outpatient services and procedures. A lot of your managed care contracts also pay a flat dollar amount for these services. Your PPS hospital should make sure that your outpatient charges are set at least to the fee schedule amount. For instance, your lab charges, your lab tests are assigned fee schedule payments, and you need to make sure that when you're reviewing your charges that your charge associated with your labs are at least to the fee schedule payment, if not more. As I mentioned, CMS and your MACs and your FIs and Medicaid are constantly making changes in coding or billing regulations, so it's important that you as a facility monitor these changes. We encourage you to update your chargemaster at least on an annual basis, and it should be reviewed not only for your reimbursement enhancement, but as I mentioned earlier, for compliance purposes. We want you to be able to charge for everything that you can charge for, but charge appropriately and make sure it's billed appropriately. So continuously monitor the CMS websites, your MAC and FI websites, your Medicaid websites, because, again, they often make changes. As I mentioned before, when you're making decisions about changing prices, first analyze what the financial impact may be. Again, if you're increasing your charges significantly, that will have a negative impact on your patient's portion that they are responsible for paying. Another hot spot that I come across in doing my medical record audits and chargemaster audits are incorrect charging documents. The charge sheets do not match what's in the chargemaster. So if your staff is relying on the charge sheets to mark or select an item that they're charging for, a supply item, or a procedure, if that document is incorrect, whether it be the CPT code that's assigned or whatever, you're going to receive inaccurate payments. So make sure that your CDM and the charge form, or if you're using electronic data entry, make sure that there's a one-to-one relationship between the two, between your chargemaster and what's on your charge forms. I'll reference the client I'm working with again right now. Every charge document that I looked at from every department, from radiology, central supply, lab, every charge document was outdated. So, of course, one of the main recommendations in my report is going to be update your charge documents so that they reflect the same information that's in your chargemasters. I don't know, or I wish I should have put a polling question in here, but oftentimes hospitals may have a chargemaster team that works together to oversee the chargemaster, and then other times you may just have one person designated as the chargemaster coordinator. But either way, it needs to be a group or team effort. Whoever, whether you've got a coordinator assigned or whether it's a team, they need to work closely with your department managers, especially from your revenue-producing departments, and work hand in hand and make sure that everybody's on the same page. They're working together to ensure that all the charging documents are accurate, and to make sure that all of the procedures that each department is performing are listed in the chargemaster and are assigned appropriate revenue codes and CPT codes. So, in summary, update your chargemaster annually. You need to look at it from both a compliance and a reimbursement angle. Again, your critical access hospitals, the revenue codes are what drives your payments in a CAH, so that is of utmost importance in reviewing your chargemaster, whereas in a PPS hospital, the CPT HCPCS codes drive your payments. So your CPT codes are very, very important in your PPS facility. Continuously monitor your websites for any changes throughout the year. Make sure that these changes are communicated. Again, if you're the coordinator, work with your department managers. If you're a team, just work as a team and make sure the information is disseminated appropriately. If you're making any pricing changes, make sure you analyze the financial impact related to those changes. And again, I can't stress the importance. We've covered a lot of information related to the chargemaster, but again, there are so many regulations that are being changed by Medicare and other payers. It's hard to stay on top of sometimes. And it gets frustrating oftentimes, but work together as a team because we want to make sure that your facilities are paid accurately for the services that they are providing. Okay, we're going to change gears just a little bit for a few minutes. I want to talk to you about the future of coding. And hopefully this does not come as any surprise to any of you. Today, as you know, we're using the ICD-9 diagnosis coding, and with discharges occurring October 1st, 2013, we are going to be moving forward to ICD-10. And I feel like I'm probably hearing some oohs or ahs or oh brothers or whatever, but yeah, it's coming and it's not far away. So we need to prepare. Preparation is the key. Question is, will you be ready? I know that the vendors are already gearing up with their software packages, getting ready to update the hospital system software related to ICD-10. There's going to be a lot of changes and training that's going to be required for coders. And it's not something that's going to occur overnight. You need to be preparing now. Right now, your Volume 1 and 2 diagnosis codes apply to all settings, and your Volume 3, which are your procedure codes apply to your inpatient hospital only. Your ICD-9 diagnosis codes that we're currently using are required under HIPAA for uniform claim submission. And your ICD-9 was developed long time ago in the 1970s. And now that we're in the 21st century, ICD-9 no longer fits our needs. And we, as the United States, believe it or not, are one of the few industrial nations that have not upgraded to the ICD-10 coding system. So we are far behind some of these other countries. ICD-9 is outdated. It's becoming obsolete because it has a limited ability to accommodate all the new procedures and diagnoses that are occurring in our modern practice of medicine now. ICD-9 lacks the precision needed for a number of emerging uses. For example, everything's going to pay for performance, so it lacks the precision related to value-based purchasing, pay for performance, or your biosurveillance. They're telling us ICD-9 does not have, or it lacks specificity needed to identify all the procedures. Because modern medicine is changing so much and so rapidly, it doesn't provide the detail needed. It uses terminology very inconsistently. ICD-9 doesn't capture the new technology that's out there, and it also lacks the codes for preventive services that Medicare is offering our patients these days. So basically, we're running out of room in ICD-9, and again, ICD-9 can't accommodate the fast-paced advances in medicine today. So it's being replaced with ICD-10, and ICD-10 will provide clinical data that will be comparable to the rest of the world. So I guess we'll finally be catching up with the rest of the world. Your diagnosis code set changes from ICD-9 Volume 1 and 2 to ICD-10, which will apply to all settings. Your hospital inpatient procedure code set changes from ICD-9 Volume 3 to ICD-10 procedure code. And here I just put on this slide, I wanted to make a little comparison looking at ICD-9 versus ICD-10 diagnosis codes. Right now we're using 3 to 5 digits or characters. When we move to ICD-10, it's going to be from 3 to 7 digits or characters. Right now, the first character is numeric or alpha in your ICD-9 coding system, and in ICD-10, we're going to be using, or the first character will be an alpha character, and every letter in the alphabet will be utilized except for the letter U. ICD-9, the second through fifth characters are numeric, whereas in ICD-10, the second through the seventh characters can either be alpha or numeric. There will be a decimal placed after the first three characters in both the ICD-9 and the ICD-10. And right now, in the ICD-9 that we're currently using, there's 17 chapters, and V and E codes are supplemental. We're going to be moving to 21 chapters in ICD-10, and your V and E codes are not supplemental codes. So what we're looking at right now, when we use our ICD-9 diagnosis codes, we're looking at or using approximately 14,000 codes. But effective October 1st, 2013, we are going to be referring to approximately 69,000 codes. That is a significant increase in the number of diagnosis codes we will be looking at. Well, you're probably wondering why there's so many diagnosis codes. Well, like I mentioned earlier, we're wanting to provide greater specificity and detail. So that means more codes for greater detail. 34,250, or 50% of all the ICD-10 diagnosis codes are going to be related to the musculoskeletal system. 50%, that's a lot of codes. 25% of all the ICD-10 diagnosis codes are related to fractures. And of those fractures, 36%, they're going to distinguish between right versus left. Again, we're talking about specificity and detail, so they're going to specify right and left. And I wanted to just briefly show you the structure format of the ICD-10 diagnosis codes that we're going to be moving to. Let's see. Your first three characters are going to refer to a category. Your second three refer to etiology, your anatomic site, and severity. And the last character has to do with extension. So this particular code tells me, or this code represents a displaced mid-cervical fracture of right femur, initial encounter for closed fracture. So in ICD-10, we're addressing categories, etiology, anatomic site, severity, and extension. So you can see the detail involved in coding beginning in 2013. Something new that ICD-10 is bringing to the table. I've got a few new items to go over. One of them is injuries are grouped by anatomic site rather than by the type of injury. your diseases of the sense organs, your eyes and ears, have their own chapter. In ICD-10, they're no longer going to be part of the nervous system chapter like they are in ICD-9 right now. New for ICD-10, they're including trimesters in your OB codes, and they're eliminating the 5th digits for the episode of care. And this may be Greek to many of you if you're not medical record people, but I just want you to realize what's involved or what's going to be involved with time and training related to changing over to ICD-10. ICD-10, there's going to be a change in time frames specified in certain codes. Also, your acute MI, the time period is changing from 8 weeks to 4 weeks. Currently, it's 8 weeks in ICD-9, and it's going to be changed to 4 weeks. Your full code titles for all your codes are going to be in the new ICD-10. You don't have to refer back to your 4th and 5th digits. So again, you can imagine how cumbersome this is going to be. And again, we're focusing on more detail, and that's what they're trying to get across, more detail and more specific. Your post-op complications, they've been moved to procedure-specific body system chapters. CMS is trying to help us out with this transition by providing us some resources. They're offering the GEM mappings, general equivalence mappings. It's not a one-to-one match for many of the ICD-9 codes, but you can go to the website that I've listed on this slide before, and you can kind of play around. You can enter an ICD-9 code, and it will take you to the equivalent ICD-10 code. Like I said, it's not a complete one-to-one matching, but CMS is trying to help us with the transition. So I encourage you to go out there on the cms.gov website and kind of play around with that. I wanted to show you an example of the specificity that we're moving to when we go to ICD-10. Currently, for a fracture of mid-cervical section of femur closed, currently we report ICD-9 820.02 for that. However, when we moved to ICD-10 in 2013, we will report any of these 3 codes. For instance, S72031A, displaced mid-cervical fracture of right femur, initial encounter for closed fracture, will be represented by any of these codes listed under number 2, 3, or 4. And again, you can see how specific they are getting. They are referring to right and left femur. In number 2, it refers to right femur. Number 3, we've got left femur. We're coding. We will be coding the encounters, whether it's an initial encounter versus the subsequent. Again, detail is what they're gearing up for. Here's another example related to diabetes. Right now with ICD-9, we use number 1, 2, and 3 codes for diabetes. Your 250.1 diagnosis code relates to diabetes with ophthalmic manifestations, type 2 or specified type, not stated as uncontrolled. Or we've got 362.06, severe non-proliferative diabetic retinopathy. And we also have diabetic macular edema represented by 362.07. They are going to roll all 3 of those ICD-9 diagnosis codes into the one code shown on the screen here, the E11341. And it's described as type 2 diabetes mellitus with severe non-proliferative diabetic retinopathy with macular edema. So whereas on the previous slide, we went from one ICD-9 code to 3 or 4, on this particular slide, we're going from 3 ICD-9 codes to 1 ICD-10 code. Again, detail is the key word. Related to our ICD-9 procedure codes, I wanted to show you a comparison of that to the ICD-10 procedures. Right now, we're using a minimum of 3 characters and a maximum